Okay, welcome back to part 2 of chapter 21 about blood vessels and circulation. Now, we ended part 1 by talking about varicose veins. So, at least, if we're talking about health-wise or health impact, at least varicose veins are usually more so a cosmetic matter. It doesn't look very nice because those veins are bulging out in your thighs or legs. But if we're talking about something like a deep vein thrombosis, or also known as short for with DVT, it occurs where a thrombus or blood clot is formed within veins, and they can impair the amount of venous return back to the heart that we talked about in the previous chapter. Remember how I listed out the different factors that can affect EDV or ESV, and the amount of venous return was one of those factors. And I did mention there that time that maybe there's a blockage in blood within the venous circulation somewhere where it's blocking blood from flowing, all the total volume of blood from flowing as easily through the veins back into the vena cava, whether superior, inferior, or if it's coming from the leg, of course, it's coming into the inferior vena cava back to the heart. And hence, if it's somehow there's a blockage somewhere, less blood goes through, and hence less blood will reach the heart, which means brings down your cardiac output. Now, other than that part of it, the other scary part of DVT is because, when we have, sometimes when we have a blood clot, it may not stay in that one position, okay? That clot can actually dislodge and become what we call an emboli, which is another term for moving clots. And when that emboli somehow gets lodged in a lung blood vessel, and sometimes those can be tiny. We're talking about those little tiny capillaries, or if the clot is large enough and plugs up a larger part of the lung arteries and capillaries, they can become a potentially fatal situation or condition called pulmonary embolism. And usually when people have that, it can be fatal for the person. Now, another interesting we want to discuss about veins is that because of their large luminal diameter, they serve as blood reservoir for our body. So what does that mean? Well, if you look at the circulation diagram right here in this image, this is drawn according to the luminal diameter of arteries versus capillaries versus veins. So the red on this side is the arteries, and then you have the capillaries here, and then you have the veins. And you can clearly see that the veins on this side of the image can contain a lot more blood than the arterial side due to its larger luminal diameter, like we talked about in terms of differences between artery and vein. So because it has a larger space, more blood can flow through this area and more blood is within this area. And hence, if we were to measure how much of our total blood volume spends in different areas of the body at any given point with this pie chart right here, almost 2/3 of your blood is actually spent within venous circulation. And like here it says only about 7% of your total blood is within the heart. And then about 9% is within the pulmonary circuit, and then 13% is within the systemic circuit, arterial side, and then you have systemic capillary, about 7%, which is what I was saying, that a lot of times not all of your capillary beds are filled with blood, so hence most of your blood is spending their time within your different venous locations. And hence, if an individual was to experience serious hemorrhaging, for example, sympathetic nerves would actually be activated to stimulate specifically venoconstriction. We talked about there's vasoconstriction, vasodilation, but sometimes in cases like these, we may want to do specifically venoconstriction, which will cause the smooth muscles of the medium-sized veins to contract, which means that luminal diameter is going to decrease Squeeze down on those blood, push all that blood that was in the veins here in this diagram, and push them towards the artery section to increase the volume of blood in the arterial and capillary system and keep the individual alive a little longer. Of course, we can't rely on that reservoir forever, because if there's severe bleeding, that means that bleeding will continue unless help has arrived to stop the bleeding from happening. But at least at the moment, your body is gonna try its best to keep you alive by having some backup of blood reservoir here, so we can keep the heart with a little bit more blood, the brain with a little bit more blood, and all the arteries that serve wherever is essential for the body to survive, to deliver oxygen to those particular areas, so we can minimize the damage we can have when your tissues runs out of oxygen. So it's a way, as like a last resort thing, to keep your body alive a little longer. Or else when tissue stops receiving blood from arteries or capillaries because there's not enough blood in there, they will start deteriorating and start to die, and tissues and cells will start to be gone. All right. And hence, in a sense, when we experience profuse blood loss, the body can still provide enough blood temporarily, excuse me for my misspelling that, temporarily, to active skeletal muscles and delicate organs like the brain. Kind of like in the movies where you see people being stabbed and they're running away from the scene, and yet you're like, whoa, they're like bleeding like crazy. How can you even run? Well, maybe that's part of that helps them power some of that skeletal muscles to keep them running. Who knows? I've never been stabbed, so I don't know how likely it is to keep running when you're being chased by a murderer. But again, remember that sympathetic kick in of the activation when you are in danger, serious danger of your life. Sometimes you might just run, but you're gonna get that blood coming from maybe this venoconstriction blood reservoir of the venous system. Okay, so now we're going to get to the physiology part of blood vessel, where it starts to feel a little bit like physics I was talking about with formulas and everything, okay? Don't get mad at me. Like I said, it's not me that want to teach this stuff, but, they gives us these objectives that we have to teach and follow and make sure you understand how blood vessels work, okay? I'm not a big fan of math too much either, but, it makes sense when we think about how our cardiovascular system is able to do what it's supposed to do, okay? All right. So the capillary blood flow is determined by an interplay between two values. One is pressure and one is resistance. And I kind of talked about that when I was mentioning vasoconstriction and vasodilation earlier within the chapter. And hence, cardiovascular pressure, is related to these three values. Oh, before I get to that, I want to make sure I get to this stuff. So pressure, resistance, and blood flow are three things that can be relevant to each other. Blood flow, which is denoted as F, is directly proportional to P, which means the higher the pressure, the more the blood flow. The lower the pressure, the lower the blood flow. Okay? And flow is inversely proportional to R. So that's why I would write flow is directly proportional to P over R, okay? Which means it's inversely proportional to resistance, but directly proportional to pressure. So the more resistance there is, the less flow there would be, okay? And this makes sense too. If we want, for example, back to that garden hose analogy I was talking about, there's water coming through the faucet, and it's kind of like, well, it's not strong enough. I gotta water that garden farther away. So what do? You turn up that faucet and make water flow more out of it. Well, why can you allow more, water through? Is because there's higher amount of pressure coming through, to push the water out into a farther place. Same thing. Now, imagine, remember I talked about how if someone accidentally stepped on the garden hose and it creates, in a sense, a resistance to flow when someone accidentally stepped on your coil of garden hose. So that stepping on the garden hose flattens that area, closes up that area, and in a sense create a sense of resistance to stop the water from flowing evenly to your opening of the garden hose. Okay, so that's why the higher the resistance there is, the more that person is stepping on your hose, the less flow you're gonna get. And if you want to increase that pressure, that flow again, of course, you're going to tell him to stop stepping on my hose. But, the other thing is you can also turn up the faucet, open it more with more pressure of water coming through, more flow would happen on your garden hose. Okay, so that's the same thing in terms of blood vessels. Okay, so make sure you remember these values in terms of pressure, resistance, and flow. We're going to come back to this idea when we talk about the type of resistance that your cardiovascular system has to overcome in order for blood flow to be continuous, to be a continuous thing throughout your entire circulation. Okay, now we're ready to move on. So the cardiovascular pressure is divided into 3 values. You have blood pressure, which starts at 120 millicurie at the aortic entrance, and usually blood pressure is measured in units of millimeters of mercury. That's the main units for pressure, and in the within the arteries, and then from the starting point of the aorta all the way to and it drops to about 35 millicurie. Okay, it's millimeter mercury, but they call it short for millicurie to have an easier time saying the whole thing. So 35 millicurie to get to the start of a capillary network. Okay, so usually I like to draw this thing for my class for in terms of the pressure that's coming out of the heart, and then it travels down to your capillaries and then comes back to the heart. Okay, so coming out of the heart, you have 120 millimeters of mercury, and then you come down all the way to the start of your capillary bed right here. Well, of course, there's a lot of capillary bed, but we're going to keep it simple just by showing one example of a capillary bed, and it begins at about 35 millicuries, and by the time the blood travels through the entire capillary, it will then become and start going into your venules and into veins and back to the heart. Okay, so let me label this as aorta, and then arteries as well, and then arterioles. Okay, so by the time you get to here, it gets down to about 18 millicurie, and then it pretty much stays the same all the way back to the heart as well. So this is the sort of more graphical way of displaying the differences in pressure coming out of the aorta, starting at the capillary, and then what it ends at before you get back to the heart via your venous circulation. It also gives you a good idea of the order of blood vessel flow for a complete cycle of cardiovascular circulation. Okay, so the second value is cos CHP, which is short for capillary hydrostatic pressure. Now, these pressure values become a very important thing when we talk about how capillary exchange is achieved. But like I said, the beginning of the capillary goes from 35 millicurie to 18 millicurie. 35 at the arterial end of the capillary, 18 at the venous end of the capillary. And this pressure comes from the force that is exerted by the fluid moving against the blood vessel wall. And the third value is called the venous pressure, which is the pressure within the majority of the venous system. Like I said, it doesn't really change much after it gets down to 18. So the pressure of blood leaving the capillary bed kind of stays within 18 millicurie and drop maybe a little bit more, a few more millicuries left before it goes back all the way back up to the heart. Okay, we'll talk about this in graphical representation as well later on in the lecture. And hence the value of circulatory pressure overall is the difference in pressure across the entire systemic circuit, which if we take 120 millicurie coming out of the aorta to about 18 millicurie coming out of the venous end of the capillary, that's about a difference of that 100 millicurie I mentioned in the beginning of the chapter. So in order for circulation to progress properly, the circulatory pressure must overcome the total peripheral resistance, which is the resistance of the entire cardiovascular system. Okay. Now, there are different, there are different parts which can contribute to the total peripheral resistance of the entire cardiovascular system. So what are they? So one of those factors comes from what's called vascular resistance, which is a force that opposes blood flow in blood vessels due to the friction between the liquid blood and the solid part of blood vessel wall. See what I mean by sounding a lot like physics? So the amount of friction that the blood vessel can have on blood flow can be attributed to two things. One is the length of the blood vessel length, and the other thing is luminal diameter of the blood vessel. The longer the blood vessel is, as represented by this image here, the more friction the blood will be exposed to, which means it will lead to a higher resistance to blood flow. So here again in this diagram, if the length of blood vessel was 1 to begin with, but if we double the length of the blood vessel to 2, for example, the surface area of the blood vessel is also double. And hence, the resistance of blood flow will also double. Because remember that we talked about how, the more friction there is within the blood vessel, the more resistance there will be. Okay, and because this is a longer blood vessel, the blood coming through has to hit more surface area compared to here, and hence that's why you have a higher resistance when you have a longer blood vessel. And it is a directly proportional relationship here. And now we talked about how flow is directly proportional to pressure over resistance, which means the higher the resistance, which is double here, the lower your flow will be, which then if it's directly proportional, then it will be half. So when resistance is doubled, the flow is also half in terms of blood vessel length. So it is a directly proportional relationship between the blood vessel length and the amount of resistance, and an indirect proportional relationship in terms of talking about resistance and how much blood flow can actually go through. On the other hand, if we talk about diameter changes, if the luminal diameter of blood vessel was half, so let's say this is what a diameter of 2 centimeters to begin with, and then you half it to 1 centimeter in this diagram here. So the resistance to blood flow actually becomes 16 times as much as the original. So somehow, okay, now we don't have to get into the physics or mathematical calculation of this. Why isn't this a directly proportional relationship? We're not going to talk about it, but it's for diameter purpose, for the factor of diameter on blood vessel, it is an exponential relationship, okay? Even though the diameter was only decreased by half the amount, amount, the resistance went up by almost 8 times as much. So you can imagine this in terms of how a tiny little straw, okay, kind of like if you try to sip from those little coffee stir straws versus a bubble tea straw, okay, so the flow of liquid going through those tiny little coffee stir straw is a lot less than those of the bubble tea straw. So because if you try to take a small sip from a coffee stir straw, probably the liquid that goes through your mouth is probably just enough to wet your mouth. Whereas if you take a small sip from a bubble tea straw, you know how big those things are, they will give you a pretty big gulp worth of liquid. So hence, this explains why our body controls blood flow by changing luminal diameter of blood vessel, because diameter has a much bigger effect in resistance compared to blood vessel length. And hence, that's why our body does vasoconstriction and vasodilation, because it is a lot more efficient in terms of both space and effect. Not only we're not taking a lot of space in the body by just making our blood vessel bigger or smaller, and it doesn't, it's not a lot of movement, and yet our resistance change can be exponentially changing, okay, just by doubling or halving the diameter size. Whereas if we're talking about blood vessels, then we're talking about stretching our blood vessels or shortening our blood vessels. That doesn't sound very efficient, okay? So it's not only inefficient in terms of space because we can't expand any more areas there is, but it also doesn't even result in a much of a change of resistance by a whole lot when you either double the length of the blood vessel or shorten the length of a blood vessel. It's just directly proportional. So that's why our body does this diameter change when we have to change how much blood goes through that particular area, or if we need to change our blood pressure. Okay, all right. So here's a quick animation video that illustrates blood flow when we change the diameter of blood vessels, okay? So here's normal blood vessels, normal size. When you do vasoconstrictions, the diameter gets smaller. When you do vasodilation, the diameter gets bigger. A lot more blood is able to flow out of it. Okay, and then back to normal. So when you constrict, less blood flow. When you expand, a lot more blood flow. So it's just a quick animation to show you that. So a second factor that contributes to the total peripheral resistance value in the cardiovascular system is blood viscosity. So this is a resistance to the flow that's caused by interaction among molecules and suspended materials in the blood. If you have more red blood cells, erythrocytes floating around, the more interaction you'll have with the fluid or the circulating antibodies around, or if there's a lot of salt ions around, things like that. Interaction amongst those things is what makes blood viscous. So one example that can affect this value of blood viscosity is, for example, when an individual has a blood disorder that affects the volume of foreign elements like anemia. And anemia, you have less blood cells, less resistance, and a higher flow. Okay, so another example would be dehydration. Okay, for example, when you are in dehydration mode, less fluid is existent within the blood. The higher hematocrit value means more foreign elements, more resistance, and less blood flow. Okay, so you have less viscous situation when you have a person with anemia, and you have higher viscosity when someone is undergoing, for example, dehydration. That can increase the viscosity, in a sense, increase in hematocrit that will need, create more resistance to blood flow when things are more viscous in the blood. Okay, so it's kind of like, moving water in a tube versus moving molasses or honey within a tube. Okay, so one is very, very viscous. You have very, very slow flow when you have a much more viscous liquid compared to a much lower viscous or lower viscosity fluid. It goes through the tube a lot easier. Okay. And the last factor that contributes to resistance is if any turbulence occurs within blood flow. Turbulence is defined as anything that affects smooth flow of blood, high flow rates, irregular surfaces, changes in your luminal diameter. All of those can contribute to turbulence within flow. And we have already talked about how turbulence in blood flow will produce a distinctive sound when listening with a stethoscope, for example, if there was a plaque in large blood vessels. So if there's a plaque like this within blood vessel on both sides or one side, whatever, instead of, all your blood moving in a straight line this way from one end of the artery to the other end of the blood vessel, it will start kind of, it goes here and then kind of like a river where you hit a rock, okay, and then it starts going all over the place. Okay, so this was what creates turbulence within the blood flow, and that can also contribute to the factor of a higher resistance. So any changes in these three factors, your blood vessel volume, okay, vascular diameter, diameter or the length, okay, so those two things, in terms of friction that's generated between the liquid and the walls of your blood vessel. Second thing is your blood viscosity level. And then third thing is the turbulence that can occur with different circumstances like plaques, formation of plaques within blood vessels. So those will overall increase your resistance or decrease it in a sense, which then will require different amount of pressure applied, for example, those coming from the heart, in order to propel the blood along in the circulatory system. So that's why this overall different stuff within the blood and blood vessel can contribute as a summary to the amount of pressure your heart has to generate in order to allow blood to flow nicely throughout your entire cardiovascular system. So now we can compare some of these different values between arteries, capillaries, and veins. Now these graphs will be very helpful when we think about how blood is flowing in these different areas of the body. If we look at the size of the luminal diameter going up from the aorta all the way to the capillaries, they go down in size as the vessels diverge into different branches of arteries, okay, and then into your capillary beds. When blood leaves from the capillaries to veins, however, the luminal diameter once again increases as blood travels toward the superior or inferior vena cava. So if you read the x-axis here, we're talking about the different types of blood vessels we have in the entire body. So it always travels in that one direction I was saying, aorta to elastic muscular arteries to arterioles to capillaries, venules, veins, and your inferior and superior vena cava. And in this graph is showing vessel luminal diameter on the y-axis. So if you don't remember on the exam, if you don't remember the values, which one has a bigger diameter again, which one has smallest, think about these graphs, okay? That's what I always tell my students. The graphs help you visualize, put it into pictorial format, what is the relationship between these different categories of blood vessels in the blood in terms of these diameter values, pressure values, surface area values, etc. Okay? All right, so in a sense, when blood gets to your venous circulation here, the blood vessels sort of converges again back into bigger tubes as they are routed back to the heart, okay? All right, so the cross-sectional area, kind of like the surface area of the blood vessel, however, is the opposite of diameter. Cross-sectional area means that if we were to cut open the blood vessel and measure the total surface area of the tube itself, that is what that means. And hence, the more numerous amount of tubes or blood vessels you have, the more surface area there will be, because we're not talking about we have gazillion of elastic arteries. We only have so many elastic arteries. We can count them. But capillaries, on the other hand, is numerous. We have lots of those in the body. So it's kind of like rolling out one garden hose tube versus 100 straws you have on your table. Okay, so if you cut open every one of those 100 straws and roll them out, and then measure the surface area of all the straws added together compared to just the surface area of a garden hose, those straws will be equivalent to a higher surface area than that one garden hose tube. Okay, I mean, considering they're the same length, let's say. Okay, so hence, the more blood vessels you have, the more surface area there will be. Okay, so for example, in the beginning, you just have one tube coming out of the heart as your aorta, and then it slowly diverges into many arterioles, followed by many capillary beds, which many of these tiny tubes together can be equivalent to a lot of surface area. And then the surface area become small again when it enters the veins. But notice that the surface area of venules here is still larger than those of the arterioles, as we have talked about, comparing the size of their lumen in the beginning between arteries and veins. So even though it still comes back down, but the overall luminal diameter of venules compared to arterioles is still, venules are a lot bigger. Okay, and hence it only makes sense that capillaries have the greatest amount of surface area, because those are the ones that will be covering over the specific tissues and organs all over the body. We have a lot of these different areas we need to cover in the entire body with different tissues and different glands, organs, etc. So that's why it makes sense that the capillaries has the largest coverage of your entire body, because they're the ones that are going to deliver those nutrients and oxygen to your tissues and organs. All right, and we have already talked about the changes in blood pressure as it travels out of the heart, and I even drew it out for you. So from the aorta, right here, you start at about 120 millicurie, and then you arrive at the capillaries here at about 35 millicurie. Exit the capillaries at about 18 millicurie, and then if that pretty much stays around that range as we reach towards the end of your vena cava. So if you relate the values we have for cross-section area with pressure, the more surface area there is, the lower pressure it will be. And hence how fast the blood can flow is another correlated value as well. As blood travels out of the aorta, there is a lot of pressure that's applied and not so much surface area. Okay, so it's going to be very fast flow. Okay, so a lot of blood will be able to flow into the aorta, and it's going very fast because that's a lot of high pressure and not much surface area, as we have seen. It will decrease as the diameter gets smaller, okay, because smaller means more friction, and then the surface area is also getting larger, which slows down the speed of the blood flow. So velocity of blood flow will be lowest around the capillary beds, which makes sense as well, because that's the whole purpose of moving blood around. It is to drop off oxygen and nutrients, and hence they should spend more time going through all those tissues to ensure that every location in the body have adequate amount of oxygen. And as blood comes out of the capillaries, the diameter gets bigger again, and the cross-section area, for example, in the veins or venules or veins, the cross-sectional area gets smaller, which will then both decrease the amount of resistance, and hence blood flow will pick back up once we're back into the venules to the vena cava. Okay, but not unknown still is incomparable to the speed that's coming out of the aorta, which is also another reason why we said a rupture aneurysm within the aorta can be fatal within minutes, because blood would just be rushing out of that area very, very quickly. All right. So although we kind of average out the pressure going from the aorta to the vena cava when we did this graph right here, we kind of averaged it out. Technically speaking, the arterial pressure is not constant due to the rise in pressure during ventricular systole and drop in pressure during ventricular diastole. So remember, systolic pressure is usually 120, whereas diastolic pressure is 80, about 80. So it kind of, this is what sets our blood pressure range to be 120 for systolic pressure, 80 for diastolic. And that's why you see this up, down, up, down, up, down. That's what accurately illustrate the pressure coming out of the aorta all the way down to the arterioles. Okay, but we kind of averaged it out to give you that graph earlier that we call the mean arterial pressure. Okay, and the fluctuation in the diastolic between the systolic and diastolic pressure kind of echoes from the aorta and slowly dissipates as it goes through the rest of the arteries and get completely gone by the time blood reaches the arterioles. So the average of the differences in systolic and diastolic pressure is known as that mean arterial pressure I was talking about. Okay, all right, give me a second here. This is my water machine that keeps making that vibration sound. I apologize for that. Okay, and hence the topic of pressure that leads us to to talk about what does it mean when we say that an individual have high blood pressure. Why is that dangerous? What does it mean for them? Okay, so when blood pressure is below the normal ranges of 120 of 80, over 80, we call this hypotension. And remember, hypo usually means going below, okay? Tension, of course, is the blood pressure, and then hyper means it's go too high. Okay, so when it goes above, we call it hypertension. Usually the systolic pressure ranging from 140 to 159 for hypertension, and then diastolic pressure would range from 90 to 99. Now, usually the incidences of hypertension is more common than hypotension, unfortunately. But pre-hypertension is when systolic pressure goes above 120. Okay, never mind, this 120 over the 139. 120 over 80 is normal. So we're talking about going above that to about 139 for systolic to 89 for diastolic. Those are when you are considered as pre-hypertension. Now, keep in mind that we are not talking about a random time of the day that you happen to measure your blood pressure and somehow it was pretty high, maybe around 135, and all of a sudden you are diagnosed with pre-hypertension. Because sometimes during different times of the day, our blood pressure will fluctuate. For example, we're stressed or, we have that sympathetic activation kicking in. That will definitely increase our blood pressure. Usually only if it's chronic, okay, meaning consistently present of that high blood pressure measurement, that's when you can confirm that it can indicate problems, even when you're calm, okay? In times of no stress, you still have the consistent chronic high blood pressure, then it indicate problems of hypertension. Usually when your physician first time seeing you coming in and measure your blood pressure was high, they will make a note, but they won't diagnose you with hypertension yet. They may tell you to come back another time and remeasure before they confirm that something can be going on, and they have to, make a diagnosis and do something about it. So why is hypertension so bad then? It definitely is not a short-term effect that we're looking at, but more so a long-term effect that will catch up on you if we leave it untreated for long periods of time. For example, one of the first things hypertension will cause is it will increase the heart's workload because the higher blood pressure means those cardiac muscles within your heart, especially those of the left ventricle, are pumping with a lot more force, and there's more pressure that have to push the blood throughout the body. Okay, so more workload on the heart, most likely your left ventricle will gradually enlarges, okay? Because you are making those cardiac muscles work harder than they need to be on an average normal healthy person. So that's why the heart muscles gets bigger, which is why when I was talking about the heart chapter that I've seen hearts as big as my face is because those were hearts from patients that had cardiovascular problems. The bigger the heart is, the more muscle mass it has, which means it will demand more oxygen. And if coronary circulation that's providing the heart with oxygen cannot keep up, it will end up with what's called coronary ischemia that we talked about in the last chapter for the heart. Now, the other dangerous long-term effect of hypertension is not just affecting your heart, but it can affect your blood vessels as well. We're talking about, again, hypertension that's consistently high, increased arterial pressure that will stress out the walls of the blood vessel because technically speaking, your blood vessels are not designed to handle that high of a pressure coming through all the time. Well, because of, the vast amount of smooth muscles we have in the arteries and those elastic fibers, they can expand, but if you're constantly bombarding your blood vessel with that high blood pressure all the time, you're going to wear them out, okay? Or else why would our homeostatic blood pressure be 120/80 if, we can go higher all the time? Okay, there's a reason why homeostasis says we have to keep our blood pressure around those numbers. So when we are bombarding our blood vessels with this strong force of blood pressure all the time, eventually is going to weaken the walls of the arteries and make them more brittle and easier to be damaged and torn. That looks just like that. So in healthy and flexible blood vessels, healthy blood vessels with normal blood pressure, blood vessels are meant to be flexible, soft, okay, allow smooth blood flow to go through. But if it's constantly bombarded with that high blood pressure, it's going to get hard. And what's going to happen is you're going to make the blood vessel more brittle and easier to be damaged and torn. And once you have a break in the blood vessel, it will then promote development of what we talked about earlier, arteriosclerosis, because that torn wall can serve as a little pocket like this. For fat molecules to store. And in that same cardiac pathology lab, I was in Baylor looking at hearts. The pathologist there actually let me feel the difference between blood vessels that were from normal individuals versus those that have passed away from heart diseases. And it was a pretty scary experience where the artery literally felt like a piece of small branch of wood or something. And when I pinched on it, it felt as hard as if I can crack it just by pressing on it. So that was insightful and enlightening moments when I was there. But as we have said, it's not a 1 day or 2 day thing that an artery can become like that. You know, we're talking about years and years of leaving your blood pressure like that, which tells us then it's never too late to turn back on one's diet and exercise and daily habits. Or sometimes, you know, in the beginning, you may need some help of medications to lower those blood pressure back to normal ranges. In the end, prolonged hypertension will only increase the chance and likelihood of aneurysms, heart attacks, and even strokes. Not saying for sure hypertension is going to give you those, but it definitely will increase your likelihood or chances of getting those problems. Okay. Now, as we have talked about previously, how pressure within the veins tend to be low and they need the assistance of valves and skeletal muscles to help with maintaining enough venous return back to the heart. Remember that venous return is defined as the amount of blood, okay, that is arriving at the right atrium per minute. Each minute. Okay, we learned from last chapter that venous return can affect the amount of EDV and diastolic volume we can have, which affects your SV, or your stroke volume of the heart, and ultimately our cardiac output. We already slightly went over one of the things that can assist with venous return, which was, and that was when we talked about skeletal muscle contraction. For example, those in our lower limbs. This is, you know, the official name for that is muscular compression, which is when, for example, when your skeletal muscles contract to help with blood moving through your veins. Or, for example, when we're standing or walking, there will be cycles of muscular contraction and relaxation to assist with that venous return. They will compress some veins and help push blood toward the heart in this cool animation here, just like that. When you contract your muscles, it squeezes down on that vein to push the blood within it upwards, which explains why, a pretty interesting phenomenon, why they always recommend us to not lock our knees when we are standing, or we're going to stand for a long period of time, especially if we're out in the sun too, that you don't lock your knees. Because when you lock your knees while standing still, the assistance of venous return from muscular compression can be lost. You're locking your knees, you're not, moving those skeletal muscles as it should, but yet those muscular contraction is what helps blood to come back to the heart. So if you're not doing that, there's no muscular compression, you're going to have a decrease in venous return. And when you have decrease in venous return, that can lead to a decrease in your cardiac output, which can reduce your, for example, blood supply to the brain, which is why people that lock their knees in the hot sun for long periods of time may experience fainting, which is temporary loss of consciousness, because now your brain does not receive enough oxygen from your cardiovascular system. Okay? So that's how muscular compression is supposed to help with the return of blood back to the heart. The second natural method in the body that assists with venous return is called respiratory pump. And this becomes a bigger impact during times of strenuous or heavy exercises. This concept is something we will talk about anyway when we get to chapter 23 on the respiratory system, which is, another long and tough chapter. So it's good that we're getting a glimpse of it now in this chapter before we get there, because when you get there, there will be more values and formulas on all that stuff. Okay, so when we're doing inhalation, what happens is you will end up with an expansion of your thoracic cavity, which then will reduce it's not blood pressure, but the pressure within the thoracic cavity, and air will be able to enter your lungs. Okay. At the same time, your venous pressure will drop within the chest because there's more room to move around, and it is easier to force blood into the inferior vena cava and your right atrium from the smaller veins of of your abdominal cavity, and your lower body. So let me draw this with you, okay? Because I'm going to redraw this again in the respiratory system anyway. So this is inhalation. Okay, here's your lungs. So what happens is your lungs is kind of like sitting on a muscle called the diaphragm. And when you're doing inhalation, your diaphragm actually contracts and flattens out, okay? So when it flattens out, it allows your lungs to expand in this large size. And when volume goes up, okay, increase in volume of the lung capacity, your pressure will decrease in terms of the gas that's within the lungs, okay? So this is going to be known as the Boyles Law when we get to the chapter 23 on respiration system. So because your pressure has dropped below atmospheric pressure, that's how air can then flow in towards your lungs. Okay, so air is able to come into your lungs. The other thing that the drop in pressure causes is, remember, this is your heart right here sitting between your lungs in the mediastinum area. And hence your inferior vena cava is about, well, I need another color. Inferior vena cava is about here, and superior vena cava is about here. And they're trying to get blood into your right atrium area. So for the fact that the pressure has dropped, it makes it a lot easier for blood to flow into the inferior vena cava and superior vena cava into those areas. Now, what happens during exhalation is, I'm going to make this really exaggerated. Your diaphragm will relax, okay, which gives that curvature again, because what happens in a diaphragm, its original shape, it has this dome shape, okay, as relaxed mode, okay? So when you're doing normal breath kind of exhalation, you're just relaxing your diaphragm, allowing your diaphragm to go back to that curved dome shape, which then pushes up on the lungs. And because when you're pushing on the lungs, you're allowing less space to be available within the lungs, so volume goes down. And according to Boyles' law, when volume goes down, pressure will go up, which means now your pressure within the lungs is higher than the atmospheric pressure on the outside in the environment. And just like how we have that concentration gradient, things always move from higher concentration gradient to lower concentration gradient. For gases, they will always move from an area of higher pressure to an area of lower pressure. So that's why air will then move out from the lung back out into the environment, and in this case CO2 specifically, because that's what's going to be your lungs will be filled with when you do have that gas exchange between the capillaries, the red blood cells in the capillaries and the alveoli within the lungs. So what else happens is you have your heart there again, and then you have your inferior, excuse me, sorry. Okay, let me quickly draw that again. Okay. You got the other part. This is not a second nature to me yet, what to click on and press on and stuff. Okay, so we talked about how pressure has increased within the lungs, which means it's also pushing on those great vessels, okay, your inferior vena cava and your superior vena cava. So it forces that pressure on there and pushes the blood inside into the right atrium of the heart. Okay, so that's what assists with the blood flow. I guess for superior vena cava, they'll just come down by gravity, but for inferior vena cava, you're fighting against gravity, trying to push that last, that bunch of blood here into your right atrium so you can start the pulmonary circuit with the right ventricle. So hence, in order to push that blood into the right atrium, this respiratory change in pressure will assist with that process. Okay, so that is why inhalation and exhalation ends up be serving as what we call the respiratory pump. Okay, respiratory pump, okay, which is this is illustrating here. During inhalation, you have decreased amount of pressure, so these blood is allowed to flow into the inferior vena cava, and when you have exhalation, you have increased pressure within the lungs, and hence that will push on the inferior vena cava, which then gives a right push to the blood into the right atrium from your those other blood from the abdominal cavity. Okay. And exhalation, which was what I was saying, will push venous blood into that right atrium. Okay? All right. So inhalation, expansion of thoracic cavity, reduce pressure. That's what allows blood in, okay, to your inferior vena cava. Exhalation, you have decrease in size of your thoracic cavity, pressure increases, which will provide that extra push for your blood to go into the right atrium of the heart. Okay, so that's how respiratory pump works, and that was how muscular compression. So in a sense, altogether, you have three things helping with venous return: the existence of valves, muscular compression, and your respiratory pump. Okay, three things. Make sure you understand how these three things work. Okay. All right. Now, another concept that we want to talk about in detail with it is the process of capillary exchange. How do the things dissolve within the plasma knows that they need to be dropped off at the arterial end of the capillary bed, and how do waste material knows that they need to be picked up again at the venous end of the capillary bed? I mean, there's no one to direct where these molecules to go or when they go. It's all based on osmotic and hydrostatic pressure that enables this process of capillary exchange to be automatic and seamless. And hence, capillary exchange is what functions to drop off nutrients and oxygen from blood to cells and remove metabolic wastes like carbon dioxide and urea from cells back into the blood so they can go to other areas for excretion or exhalation. Now, we have already mentioned that the blood flow through capillaries are usually very slow, and it makes sense because we need enough time to allow for diffusions and active transport across those capillary walls. There are three important processes that happens across capillary walls. One being called diffusion, very easy as we know what diffusion is already. These are things traveling from an area of higher concentration to an area of lower concentration, and different materials will cross the capillary walls via different methods. For example, water and small organic molecules will just diffuse between gaps of those endothelial cells or through the pores of fenestrated capillaries we talked about. Many ions, however, will diffuse via channels. Larger water-soluble compounds only goes through fenestrated capillaries, while lipids like steroids, oxygen, carbon dioxide, those will be able to diffuse right through the plasma membrane of the capillaries. And plasma proteins are only able to diffuse through sinusoids. So wherever there's area that is just continuous capillaries or fenestrated capillaries, plasma proteins cannot cross over the capillary into the interstitial fluid. Only when there is sinusoids then they can do that. Okay. And we'll talk about diffusion of gases we'll emphasize that again when we get to the respiratory system, how for gases is the same as concentration of solutes, where a higher pressure of the gas will travel to an area of lower pressure of the gas. Okay, but we'll get to that in the respiratory system. Now, another type of processes that happens is called filtration. Now, filtration is where solutes will move from the blood across the porous capillary membrane into nearby tissues and cells. So I'll write that down. We're talking about solutes crossing over to the from capillary into cells or tissues. Because somehow, it happens with some students that keep getting confused between filtration and reabsorption. To them, filtration sounds like things coming back into the blood. That is not correct. Okay, filtration is talking about things that move from your blood into your interstitial fluid or the cells and tissues that the interstitial fluid is surrounding. Okay, so this filtration primarily takes place at the arterial end of the capillary. Remember, we talked about how capillary, you have the arterial end beginning at 35 millicurie and then the venous end at 18 millicurie. So at the beginning, arterial side of the capillary, usually filtration happens, and we'll talk about why that's the case with a little bit of math. Usually water and small molecules can cross the capillary wall, whereas larger proteins like these, blood proteins, albumins that we talked about as part of being in the plasma, will remain in the blood. So that's why I talked about how the movement of molecules or pressure that's generated is set by the existence of these things in the blood that creates an osmotic pressure within the blood vessels. Okay, I'll come back to that in a bit. All right, so the last type of processes that happens is reabsorption, where fluid along with solutes will move from the surrounding tissues or cells back into the blood. Okay, so I'm going to write solutes from cells or tissues back into blood. Okay, so this happens due to something we learned about already last semester and in your general biology classes, called osmotic pressure. The higher the solute concentration, the greater the osmotic pressure you're going to have. And for blood, there are all these suspended plasma proteins we talked about that cannot cross these capillary walls. So they create a special type of osmotic pressure called the blood colloid osmotic pressure, or short we'll call it BCOP. Okay. Blood colloid osmotic pressure, meaning something in the blood that's, for example, those dissolved proteins as within the plasma that gives rise to this osmotic pressure within blood vessels. And we'll come back to what value this is and how this is come into play in terms of reabsorption in a bit. Okay, and hence the amount of fluid that flows out of blood is called filtration, and the fluid that flows back into blood is called reabsorption, as we have talked about. And this overall is called bulk flow within capillaries. There are four main functions that bulk flow allows for. First of all, they ensure plasma and interstitial fluid will communicate and be able to exchange materials. If no bulk flow occurs, no filtration, no reabsorption, capillaries are pretty much useless, because that's the whole purpose of capillaries, is to allow things to move out and allow unnecessary things to go from the tissues back into the blood to travel elsewhere. They will accelerate distribution of nutrients, hormones, and dissolved gases in tissues, assist in transport of insoluble lipids and proteins that cannot cross your capillary walls, enter the bloodstream, and flushes out bacterial toxins and other chemicals. So these are the 4 functions that bulk flow serve to assist with, okay, in our circulatory system. Okay, so it's been an hour, so this will be in our part 2, and we will continue with part 3 of the lecture video.